We're tackling one of the most complex, vital, and frankly, information-dense organs in the body, the eye.
It really is.
It's a sensory organ, a complex hydrodynamic system, and a perfectly transparent window into our systemic health, all at once.
Oh.
I mean, the sheer number of specialized tissues packed into this tiny sphere is just mind-boggling.
It truly is. And this deep dive, it's built on a massive foundation. We're looking at detailed textbook excerpts, specifically the chapter covering the architecture and the afflictions of the eye.
Right.
Our mission here is to gain a rapid, comprehensive, but most importantly, an interpreted understanding of its functional anatomy, the major diseases, and, critically, the microscopic pathology of these conditions. We have to connect the dots between structure and disease right down at the cellular level.
And the sources we're using are unique because they don't just list diseases. They integrate the descriptive anatomy, the clinical pathology, and these incredibly detailed descriptions of specific microscopic slides, the high-power H&E views. We are essentially treating the diagrams and the morphology notes as essential visual evidence to bring the science to life for you.
What's fascinating here is the paradox. The eye's function demands perfection, perfect clarity, perfect pressure, but its structure is incredibly fragile. This high specialization, from the cornea's crystalline clarity to the retina's dense neural layers, it dictates how diseases manifest, how they progress, and ultimately how they steal vision. We'll be connecting the anatomical what to the pathological why it matters for conditions that profoundly impact quality of life.
So to structure this journey, we're starting with the foundational architecture, the cross-section of the eye, and moving layer by layer. We'll go from the protective orbit and the external adnexa inward to the light-sensitive retina and that crucial optic nerve connection to the central nervous system.
It's going to be a fascinating, detailed journey into the fragility and the resilience of sight.
All right, let's begin with the big picture, the container itself. Our source material provides this detailed anatomical cross-section that can really serve as our foundational map.
Okay.
So before we jump into pathology, let's clearly establish the primary components that are essential for vision.
Absolutely. If you visualize the eye as 3 concentric layers, that really helps organize the anatomy.
Yeah.
The outermost layer is the sclera. That's the tough, protective white coat. The middle layer is the highly vascular choroid, which acts as the major blood supply and nutritional layer. And then the innermost, most critical layer is the retina, the neural tissue that captures light and converts it into electrical signals.
And as we move forward toward the front of the eye,
the front surface is the cornea, which has to remain perfectly transparent. It provides the vast majority of the eye's refractive power.
right, the main focusing lens.
Exactly. Behind the cornea, we find the iris, which uses muscular fibers to control the pupil size and regulate light entry, and then the lens, which dynamically fine-tunes that focus.
What about the fluid dynamics?
Then there's the circulatory system of the eye. The ciliary body forms the aqueous humor, and the trabecular meshwork is the primary system for draining that fluid. Posteriorly, all the neural fibers converge to form the optic nerve, which is accompanied by the central artery and vein. This whole structure just highlights the incredible anatomical balance required for optimal vision.
Okay, moving beyond the eyeball itself, let's look at the supporting cast. The orbit. Our sources emphasize that the orbit's primary function is containment. It's a bony, confined space. Why is that description of the orbit as a closed compartment so functionally important when we start discussing disease?
Because it's a non-yielding space. That's the key. The orbit is designed to hold and protect the eye, sealed off by the bones of the skull. The key functional consideration, as the sources strongly emphasize, is that any disease process that increases the volume of tissue within this confined space, be it inflammation, edema, fluid, or a tumor, has nowhere to expand but forward.
And that displacement forward is known as proptosis or exophthalmos. So if the volume inside increases, the eye just bulges out. What are the immediate and, I imagine, severe clinical consequences of this displacement for the patient?
Well, the most immediate clinical threat is chronic corneal exposure.
Meaning the eye dries out.
Exactly. If the eye is pushed forward significantly, the eyelids, which are designed to be mobile and cover the eye fully during sleep or blinking, they just can't meet. The cornea, which needs constant lubrication from the tear film, rapidly dries out.
And that leads to?
It leads swiftly to desiccation, then ulceration, infection, and tremendous pain. If the process is reversed, a loss of orbital contents can cause an ophthalmos, where the eye sinks backward. In essence, the orbit becomes a biological pressure cooker when diseases take hold.
One of the classic systemic diseases that directly and profoundly affects the orbit is thyroid ophthalmopathy, most frequently associated with Graves' disease. So for you, the listener, this means an endocrine problem. A thyroid hormone imbalance manifests physically as an eye problem. What's the precise mechanism driving the proptosis here?
The mechanism is entirely immunologically mediated, but it targets specific orbital components. It's not an excess of thyroid hormone itself, but an autoimmune process where the body produces antibodies that cross-react with antigens found on both the thyroid gland and on the retrobulbar tissues.
And that targets the muscles.
Specifically, it causes the inflammation and swelling of the rectus muscles, the muscles that move the eye.
Okay, and how does that translate to the microscopic pathology, what's happening at the cellular level?
That inflammation triggers the accumulation of massive amounts of extracellular matrix proteins, things like hyaluronic acid, and over time, varying degrees of fibrosis in the rectus muscles.
With swelling and scarring.
It's a combination. This swelling and subsequent fibrous hardening of the muscle bellies physically pushes the globe forward, causing what we call axial proptosis. And because the muscles are stiff and swollen, it also causes painful, restricted eye movement.
We have a visual reference for this in the source material, an illustration of a gross dissection. If we were looking at that image right now, how would we distinguish a muscle affected by Graves' disease from a healthy one?
The visual evidence clearly shows the selective nature of this disease. The illustration shows that the tendons of the extraocular muscles are visibly spared. They remain thin and white.
Right.
However, the muscle bellies themselves are greatly distended and thickened, looking swollen and fleshy. This selective thickening, affecting the belly but sparing the tendon, is highly characteristic of the condition and explains both the proptosis and the restricted range of motion.
So beyond these systemic body-wide causes, the orbit can be affected by chronic, nonspecific local inflammation, known as idiopathic orbital inflammation, or pseudotumor. The name implies a mass, which is often what the patient presents with, but what is the diagnosis actually based on?
As the name suggests, it's a diagnosis of exclusion. It is chronic inflammation that occurs without a definitive systemic cause.
So you've ruled everything else out.
We ruled out infection, Graves' disease, sarcoidosis, and other known causes. It is essentially a localized inflammatory response that can affect any or all orbital tissues, the fat, the muscles, the lacrimal gland, or the nerve sheaths.
Let's delve into the H&E morphology for this, because that is where the diagnosis is confirmed and differentiated from a true malignancy. What is the microscopic signature of a pseudotumor?
Well, the microscopic slide reveals orbital tissue that's intensely infiltrated by what we call a chronic inflammatory infiltrate. The dominant cells are lymphocytes and plasma cells, the classic agents of chronic immune response, often mixed with occasional eosinophils.
And it's organized.
Crucially, in a significant number of cases, this inflammation is highly organized, sometimes forming recognizable lymphatic structures known as germinal centers, which suggests a hyperactive local immune response.
And what happens to the normal tissue of the orbit in this process?
This inflammatory process is destructive. You see that the normally loose, almost sponge-like orbital fat, which is there at pad and cushion the eye, is often replaced by dense, fibrotic, scar-like tissue.
So that fibrosis itself adds to the mass.
It replaces the normal structure, and this hardening and shrinkage of the tissue contributes significantly to the mass effect, driving the proptosis and causing the tissue to feel rigid. This histopathology, a chronic, mixed infiltrate with fibrosis, is key to identifying this condition and separating it from a true, organized neoplasm.
That dense fibrosis really highlights that the mass effect isn't just fluid swelling, it's actual structural changes pushing the eye out. Now let's consider orbital neoplasms. If anything takes up space in this confined environment, it causes profound symptoms, and the orbit is full of specialized tissues.
Exactly. Tumors can arise from any specialized tissue in the orbit: the lacrimal gland, the optic nerve sheaths, the muscle tissue, the fat. The classification of these tumors follows the standard WHO system.
But what's the most common type?
What is highly noteworthy is that the most frequent primary tumors found in the orbit are vascular in origin.
Which vascular tumors are those, and how do they differ clinically?
We typically encounter two major types. First, the capillary hemangioma, often seen in infants and children. These are usually benign, frequently encapsulated, and may even spontaneously regress.
And a second.
Second, the cavernous hemangioma, which is generally found in adults. These are also usually encapsulated, but they tend to grow slowly over time.
So regardless of the cell of origin, be it vascular, neural, or epithelial, what is the central pathological principle that links all these orbital lesions and dictates the patient's symptoms?
The core principle is straightforward: mass effect. Any mass, whether it's an inflammatory pseudotumor or a true neoplasm like a hemangioma, causes symptoms by pushing neighboring structures. It causes proptosis, or it compresses the delicate optic nerve.
And optic nerve compression is the real danger to vision.
It's particularly dangerous because it leads to vision loss that is often insidious and painless, meaning the patient may not seek help until significant damage is already done. The key insight here is that in the orbit, space is vision.
Moving from the protective containment of the orbit to the structures that actively shield and lubricate the eye, the eyelid and the conjunctiva. The eyelid is far more than a simple curtain. It's an active player in generating critical components of the tear film and protecting the globe from trauma and desiccation.
And just like any skin-covered structure, the eyelid is susceptible to skin cancers, especially given its constant exposure to UV light. The sources point out that the most common malignancy of the eyelid is basal cell carcinoma, or BCC. And while BCC is a serious concern, it's locally invasive and destructive, requiring complete excision. It is typically non-metastatic.
But there's a rarer, far more dangerous malignancy lurking here that can be easily missed, and that is sebaceous carcinoma. You highlighted that this tumor is treacherous. Why is it so lethal relative to other eyelid tumors?
It is lethal for two main reasons: its inherent aggressiveness and its clinical masquerade.
Masquerade, what do you mean?
I mean, it pretends to be something else. While significantly rarer than BCC, sebaceous carcinoma has an alarmingly high mortality rate, often reported to be 20 to 30%, particularly if the diagnosis is delayed. Clinically, it often mimics extremely common benign inflammatory conditions.
What does it mimic?
It often looks exactly like a chronic persistent chalazion, which is a blockage and inflammation of a sebaceous gland, or chronic blepharitis, which is just general inflammation of the eyelid margin. So if a doctor sees a persistent lump or a red eyelid, they might treat it for months with simple warm compresses or antibiotics, believing it is benign inflammation.
That sounds like a terrifying recipe for a lethal delayed diagnosis. If the patient is being treated for a benign condition while the malignancy progresses, where does the tumor spread?
The delay is lethal because the tumor is uniquely adept at spreading through the intraepithelial route, meaning it spreads along the surface of the epithelium, often very subtly. It can move into the conjunctiva, spread across the eyelid surface, and ultimately reach the tear drainage system, eventually accessing regional lymph nodes.
And once it hits the lymph nodes?
Once it spreads via the lymphatics, the prognosis drops dramatically. We also must note its association with Muir-Torre syndrome, a genetic condition that predisposes patients to this and other visceral malignancies.
To truly capture the danger, we have to look at the pathology. If we analyze a microscopic slide of this sebaceous carcinoma, what are the definitive features that separate it from a benign inflammation?
The slide is critical. It shows a moderately differentiated sebaceous carcinoma. The characteristic feature is the large number of tumor cells displaying vacuolization of the cytoplasm, this clear, bubbly appearance where the lipids are stored.
Okay.
But the most alarming sign microscopically is the pagetoid spread.
What does that mean for the listener?
Pagetoid spread means the tumor cells are spreading individually within the surface layer of the epidermis, similar to what you might see in Paget disease of the breast. This is intraepithelial involvement that dramatically complicates surgery because the surface margins are already involved, indicating a wide, subtle spread and significant invasive potential. It's a cancer that hides in plain sight, both clinically and microscopically.
Let's move to the conjunctiva, the transparent, thin membrane that covers the inner eyelid surface and the white part of the globe. What is its structural and functional role in maintaining eye health?
The conjunctiva is structurally divided into zones: the palpebral on the lid, the bulbar on the globe, and the fornix, which is the fold. Functionally, it contains accessory lacrimal tissue for tear production and, most importantly, critical mucus-secreting goblet cells.
Goblet cells.
Yes. These cells generate the vital mucus layer of the tear film, which helps anchor the watery tears to the ocular surface, keeping the eye moist and stable.
And when this delicate structure is subjected to severe inflammation, particularly from a chronic infection, what is the long-term consequence for the eye?
Chronic scarring is the major consequence. Our source material emphasizes the long-term consequences of infections like trachoma, which is caused by Chlamydia trachomatis. Chronic, repeated infection leads to intense conjunctival scarring.
And that scarring changes the tissue itself.
Yes, this scarring causes the smooth mucosal tissue to undergo keratinization. It transforms into a rough, skin-like tissue. This process causes tremendous irritation, mechanical abrasion, and severe dry eye because the essential goblet cells are destroyed and the tear film can no longer stabilize.
And just like the eyelid, the conjunctiva is susceptible to malignancies, particularly in sun-exposed areas. What are the main types we need to be aware of?
We see two primary types. First, squamous cell carcinoma, which often starts as conjunctival intraepithelial neoplasia, or CIN, that's a precursor stage, before progressing to invasive carcinoma. This is usually managed well if caught early.
And the second, more dangerous one.
Second, and far more sinister, is conjunctival melanoma.
Melanoma always raises red flags. How does the pathology and genetics of conjunctival melanoma compare to the more common skin or uveal melanomas?
Conjunctival melanomas are usually unilateral and present as complex pigmented lesions. Genetically, they share a common thread with uveal melanoma, often showing mutations in GNAQ, GNA11, or sometimes BRAF. However, its prognosis is governed by a different route of spread than uveal melanoma.
And that route is?
Regional lymph nodes. The conjunctiva has lymphatic drainage, and if the tumor breaches the basement membrane and gains access to those lymph channels, metastasis is highly likely. The source data is sobering. It indicates that up to 25% of patients will succumb to metastasis, usually due to spread to the lymph nodes and beyond.
So a clinician must always prioritize ruling out lymphatic spread in these cases.
Absolutely, as it significantly worsens the patient's outlook.
Now we move inward to the tough outer layer of the globe, the sclera. This is the eye's primary external defense, a thick, fibrous wall made primarily of collagen. What's the key to understanding its biological function and, I guess, its limitations?
It's biological inactivity. The sclera contains very few blood vessels and very few active fibroblasts. It is tough, like a ship's hull, but metabolically sluggish.
So it doesn't heal well.
Because of this limited cellular and vascular supply, surgical incisions or injuries to the sclera tend to heal poorly and slowly. It's a structurally strong wall, but once damaged, it really struggles to self-repair.
When this tough wall becomes inflamed, a condition called scleritis, it often signals a deep systemic problem, correct?
Absolutely. Scleritis, particularly the destructive necrotizing type, is frequently a sentinel sign for systemic autoimmune diseases. The classic association is severe, active rheumatoid arthritis. It's another powerful example of the eye acting as a diagnostic mirror, reflecting a body-wide inflammatory assault.
One of the most striking clinical signs noted in the source material is the blue sclera phenomenon. This sounds dramatic, but it's a critical diagnostic signal that requires immediate attention. What makes the usually white sclera appear blue?
It's an optical illusion driven by thinning. The sclera is normally thick and opaque white. The blue appearance results when the sclera becomes thin enough for the underlying darkly pigmented uvea, the choroid, to show through.
And there are a few reasons this could happen.
There are three primary causes for this dangerous thinning. The first is thinning after repeated severe episodes of scleritis. The inflammation literally eats away at the collagen.
And the other two causes link directly to genetics or congenital issues.
Correct. The second cause is a deep underlying congenital pigmented nevus, like a large birthmark known as nevus of Ota. And the third and most critical is the systemic condition osteogenesis imperfecta, the brittle bone disease. The genetic defect in collagen production that causes fragile bones also affects the collagen in the sclera, making it congenitally thin and translucent. Seeing a blue sclera should immediately prompt an investigation for a systemic collagen disorder.
Let's transition to the cornea, the ultimate requirement for clear vision transparency. The anatomy of its 5 layers is crucial. The textbook emphasizes that the cornea provides the majority of the eye's refractive power. How does its structure ensure that perfect clarity?
Well, clarity is maintained by a highly specialized structure. The middle layer, the stroma, consists of highly organized parallel collagen lamellae that minimize light scatter. Second, its clarity depends on its strictly avascular state. It naturally lacks blood vessels and lymphatics. Any vessel growth is pathological.
And the third feature relates to its hydration and the barrier layers.
Exactly. The cornea has 5 distinct layers: the epithelium, the acellular Bowman layer, the stroma, the thin descendant membrane, which is the basement membrane of the innermost layer, and finally, the endothelium.
And the endothelium is key.
The endothelium is the key cellular layer responsible for pumping excess fluid out of the stroma, maintaining its critical state of deturgescence, a precisely balanced, slightly dehydrated state. If the cornea is too hydrated, it swells and becomes cloudy.
I see why the vascularity is so important now. If there are no vessels or lymphatics, there are no resident immune cells, which explains why corneal transplants have such a high success rate compared to other grafts.
That's a critical realization. The immune privilege of the cornea, thanks to its vascularity, is a unique biological advantage. However, if that vascularity is compromised, if new vessels start growing in, a process called vascularization, it immediately reduces transparency and introduces chronic inflammatory cells, which inevitably leads to scarring and severe vision compromise.
Let's talk about infections. Corneal ulcers can be caused by various pathogens. The source material draws attention to chronic herpes simplex keratitis as a source of severe chronic damage. What does the microscopic pathology show us about the long-term effects of this viral infection?
If we look at the histopathology of a cornea affected by chronic herpes, we see profound scarring and inflammation deep within the tissue. The specific finding mentioned is the presence of numerous fibroblast cycles in the descendant membrane.
What are fibroblast cycles?
They are essentially tiny repetitive waves of healing and scarring, where fibroblasts, the scar-forming cells, are activated by the persistent viral presence and repeated inflammatory assaults. This continuous, low-grade scarring compromises the structural integrity of the descendant membrane and the clarity of the adjacent stroma.
So it's a constant cycle of damage and repair.
Exactly. Chronic herpes is a textbook example of how viral persistence triggers continuous destructive inflammatory cycles that relentlessly damage the deep corneal layers.
Moving beyond infection, let's analyze keratoconus, a non-inflammatory degenerative condition where the cornea progressively thins and takes on an irregular cone shape. What are the key microscopic findings there?
The morphology defines the condition. It's characterized by the progressive thinning and bulging, or ectasia, of the corneal stroma. The hallmark findings visible on high-power examination are the thinning of the stroma and multiple tears or breaks in the Bowman layer.
And that causes the visual distortion.
Right. Because the cornea thins unevenly, it forms an irregular cone, leading to disabling irregular astigmatism.
And this structural weakening can lead to a sudden catastrophic failure called hydrops. How does a patient experience this, and what is the underlying mechanism?
Hydrops is a medical emergency and a sudden, painful event. It occurs when the already stressed and weakened descendant membrane precipitously ruptures.
Wow.
Since this membrane is the barrier between the fluid-filled anterior chamber and the stroma, its rupture allows the aqueous humor to rush rapidly into the corneal stroma. This sudden influx causes massive acute corneal edema swelling and severe, painful visual blurring. It's a dramatic structural failure that usually resolves over months, but it leaves behind severe scarring.
We also need to underscore the systemic connections here, as keratoconus is not always an isolated ocular issue.
That's correct. It is significantly associated with systemic conditions, particularly Down syndrome and Marfan syndrome, suggesting an underlying genetic predisposition to connective tissue weakness. It's also often exacerbated by mechanical trauma like chronic vigorous eye rubbing, which is common in atopic or allergic individuals.
Finally, in this section, we must cover Fuchs' endothelial dystrophy. While maybe less dramatic than hydrops, this condition has massive clinical relevance in the U.S.
It is the single leading indication for elective corneal transplantation in the United States. Its entire pathology revolves around the failure and loss of the crucial endothelial pump cells. These cells, which do not regenerate, are essential for maintaining that state of detergescence.
So as those cells are lost, what is the consequence for the cornea?
As the endothelial cell count drops, they stop pumping fluid efficiently. This leads to chronic stromal edema, causing the cornea to swell and become permanently cloudy. This eventually progresses to bullous keratopathy, the formation of fluid-filled blisters, or bullae, on the corneal surface, severely compromising clarity and causing a lot of discomfort.
So the key concept summarizing this entire section is that the clarity of the cornea depends entirely on maintaining both the function of those relatively few, non-regenerating endothelial cells and the cornea's strictly avascular state.
Precisely. Any inflammation, trauma, or genetic failure of the endothelium immediately compromises the perfect clarity required for sight.
Let's move deeper into the eye, focusing on the anterior segment, the area defined by the cornea, iris, and lens. This area is defined by fluid dynamics and pressure, summarized beautifully by the circulation of aqueous humor.
This fluid is absolutely crucial for maintaining the shape of the eye and providing nutrition to the avascular structures, like the cornea and lens. The source highlights that aqueous humor is actively formed by the secretory cells in the pars plicata of the ciliary body.
And it flows where?
It flows from the posterior chamber through the pupil into the anterior chamber, and then it drains.
And the drainage path is the critical point. right?
Yeah.
That's where things can go wrong.
It is. The primary drainage route, responsible for about 90% of outflow, is via the trabecular meshwork into the Schlem canal, which is a circumferential venous channel. A secondary drainage route is the uveoscleral outflow. This continuous production and drainage has to be perfectly balanced to maintain normal intraocular pressure, or IOP.
Before we discuss pressure problems, let's quickly address the lens and cataract formation. What defines a cataract pathologically?
A cataract is simply the term for any opacification of the lens. They can be congenital, caused by infectious agents or genetic anomalies, or more commonly, acquired.
And what causes acquired cataracts?
They're linked to systemic diseases like long-term diabetes or galactosemia, the use of certain drugs, most famously corticosteroids, or direct trauma and radiation exposure.
And the specific morphological change we see in the most common age-related acquired cataract.
Nuclear sclerosis. This is the hardening and opacification of the central core of the lens. As we age, the lens nucleus accumulates urochrome pigment, which transitions from clear to yellow and sometimes even dark brown. This accumulation literally changes the optical properties of the eye.
Our sources made a fascinating connection to art history regarding this pigmentation.
Yes, the accumulation of this yellow to brown pigment can severely distort an individual's perception of color, particularly affecting the blue end of the spectrum. It has been hypothesized that the predominance of yellow and ochre hues in some of Rembrandt's late-life paintings may be a direct consequence of his own advanced nuclear sclerotic cataract, which acted as a permanent brown filter over his world.
Wow, that's a powerful illustration of how pathology directly impacts perception.
It really is.
That's a wonderful way to contextualize the pathology. Now let's return to pressure. Glaucoma. It's often oversimplified as just high eye pressure, but our sources define it by its final result.
Glaucoma is a collection of diseases, all sharing two definitive findings: distinctive, progressive changes in the visual field and characteristic damage to the optic nerve, specifically an increase in the size and shape of the optic nerve gut.
So high pressure is the risk, not the disease itself.
While elevated IOP is the primary and most treatable risk factor, the definitive endpoint of glaucoma is the irreversible damage to the optic nerve.
We have two primary mechanical classifications for glaucoma, based on where the outflow problem lies relative to the iris and cornea.
First, open-angle glaucoma, which is the most common form, affecting millions globally. In this type, the angle between the iris and the cornea is physically wide open, but the outflow through the crucial trabecular meshwork is pathologically reduced.
So it's like a clogged drain.
It's a functional or microscopic blockage, perhaps due to aging changes, debris, or a chronic stiffening of the meshwork tissue, leading to slowly rising chronic IOP.
And the second type, which is often an acute emergency.
Angle closure glaucoma. This is a physical or mechanical problem. The iris bows forward, often suddenly, and physically butts up against the peripheral cornea, blocking the aqueous humor from even reaching the trabecular meshwork for drainage. This leads to a sudden, often very high, painful increase in IOP.
We must also address secondary glaucoma, which stems from other pre-existing ocular or systemic diseases. A critical and highly aggressive example is neovascular glaucoma. What is the systemic driver here?
This is a devastating consequence of profound ischemia, often seen in advanced diabetic retinopathy or following large retinal vein occlusions. When the retina is starved of oxygen, it acts on its own defense mechanism by producing huge amounts of VEGF, vascular endothelial growth factor.
And that VEGF doesn't stay put, it travels forward.
Exactly. This VEGF diffuses into the anterior segment and causes the explosive growth of abnormal, fragile new blood vessels called neovascularization. These vessels grow directly over the surface of the trabecular meshwork, forming a web that physically and rapidly impedes the outflow of aqueous humor.
So it's an even more aggressive clog.
It often causes an intractable increase in IOP, making it one of the hardest glaucomas to manage.
Let's transition now to severe acute intraocular inflammation. Our sources make a clear pathological distinction based on anatomical spread: endophthalmitis versus panophthalmitis. What is the boundary that separates these two highly destructive conditions?
The boundary is the structural wall of the eye, the sclera and choroid. Endophthalmitis is inflammation confined to the eye's internal structures, the anterior segment, the lens, and the vitreous humor. It does not breach the structural coats.
Panophthalmitis signifies a total breach.
Yes. Panophthalmitis is the generalized severe form. The intense inflammation has extended beyond the eye's internal structures and involves the entire wall, the retina, choroid, and sclera, potentially reaching the surrounding orbit.
So it's a much more dangerous, widespread infection.
It indicates a far more widespread, usually bacterial and destructive infection that requires immediate and radical treatment.
The source material provides a dramatic illustration of panophthalmitis, showing an eye that was removed after a foreign body injury. What does the gross pathology of this image reveal about the condition's severity?
That image is very telling. It shows intense, diffuse suppurative inflammation, the presence of massive amounts of pus and inflammatory cells that is spread throughout all the intraocular contents. But the key sign of panophthalmitis is seeing the inflammation extending right out to the surface layers, noting the adhesions and inflammatory infiltration involving the sclera itself. It is a physical manifestation of total structural destruction and inflammatory infiltration of the entire globe.
We are now focusing on the uvea, which is comprised of the iris, the ciliary body, and the choroid. The uvea is functionally defined by one thing. It is the most highly vascularized tissue site in the entire body, which makes it central to both inflammation and metastasis.
That intense vascularity is the definition of the uvea. Consequently, inflammation of the uvea, or uveitis, is frequently a powerful manifestation of systemic disease or infectious agents that are spread through the bloodstream.
What systemic diseases are often first diagnosed by the presence of uveitis?
A wide range of autoimmune conditions. We see links to rheumatoid arthritis, various spondyloarthropathies, and very classically, granulomatous conditions like sarcoidosis.
So if you suspect a systemic granulomatous process, you look for a very specific microscopic pattern in the inflamed tissue.
Yes, and if we analyze that pattern based on the provided H&E analysis of a specific form of uveitis, we can see what defines it.
What defining morphology points toward a granulomatous cause?
The slide shows the classic pattern of granulomatous inflammation. This pattern is characterized by dense aggregates of modified macrophages, which have failed to clear the inciting agent. These macrophages often fuse together to form massive multinucleated giant cells.
Right.
The presence of these giant cells, often surrounding debris and surrounded by lymphocytes, is highly characteristic. In the eye, this pattern immediately suggests sarcoidosis, or the unique condition known as sympathetic ophthalmia.
Speaking of sympathetic ophthalmia, this is one of the most clinically crucial and perplexing rare conditions. It's an autoimmune paradox. What is it, and why is it termed sympathetic?
Sympathetic ophthalmia is a rare but profound bilateral granulomatous uveitis that only occurs after a penetrating injury to one eye, the exciting eye.
So it happens in the other eye.
It's an autoimmune response. The initial trauma exposes previously sequestered uveal antigens molecules the immune system has never seen before to the systemic circulation.
So the immune system mounts a response against those antigens.
Yes, a delayed type hypersensitivity reaction, which then mistakenly attacks the uninjured or sympathetic fellow eye, sometimes weeks, months, or even decades later. This stresses the incredible importance of early recognition and treatment of penetrating eye injuries to prevent this catastrophic bilateral damage.
Let's transition to the most common primary intraocular cancer in adults, uveal melanoma. Given its home in the choroid, the most vascular tissue, what are the primary risk factors and the major genetic drivers that determine its lethality?
It primarily affects Caucasians with increased risk for lighter eye color. Genetically, the key drivers involve mutations in the G protein-coupled receptors, primarily GNAQ and GNA11. But the most crucial prognostic marker is the status of the tumor suppressor gene BAP1 on chromosome 3.
And BAP1 loss is bad news.
BAP1 loss is strongly correlated with a high risk of metastasis.
The prognosis for uveal melanoma is determined not just by the size of the tumor, but critically by the specific cell type seen under the microscope. This is where the pathologist makes the vital distinction. What are the two critical cell types, and why is one so much worse than the other?
We classify them based on the cellular morphology. We have spindle cells, which are thin, elongated, and typically associated with a better prognosis, and the more aggressive epithelioid cells.
Why are the epithelioid cells so dangerous?
They are spherical, much larger, and display far greater cytologic atypia, meaning they look highly abnormal and disorganized under the microscope. Their presence, especially if they're the predominant cell type, indicates a much worse prognosis and a higher likelihood of metastatic spread.
The high-power H&E of an epithelioid melanoma reveals a specific structure that helps explain this aggressiveness and vascular access. What is the pathological structure called, and what does it signify?
We look for structures known as looping, slit-like spaces surrounding the tumor cell nests. These are not true functional blood vessels lined by endothelium. Instead, they are the product of vasculogenic mimicry.
So the tumor is building its own fake highways.
Exactly. It's a mechanism the epithelioid melanoma uses to create its own internal vascular network, independent of the host's supply. This greatly enhances its ability to access the highly vascular choroid in the bloodstream, which is why it has such a devastating high metastatic potential.
The clinical photograph of this condition provides a visual warning sign. It contrasts a small lesion with one that has progressed, grown, and ruptured, a crucial anatomical layer.
The comparison is stark. The progressed lesion has grown significantly in size and thickness, and critically, it has breached the Bruch membrane, the barrier separating the choroid from the RPE and retina. When the tumor breaks through, it often creates an overlying retinal detachment and confirms a higher risk of invasion and hematogenic spread.
Given the epithelioid cells and this vasculogenic mimicry, what is the ultimate tragic fate of many uveal melanoma patients?
The metastasis rate is high and predictable. Spread occurs almost exclusively via the hematogenic route, meaning through the blood, not the lymphatics. Uveal melanoma has a notorious and unique predilection for metastasizing to the liver.
To the liver specifically.
Yes, and even after successful treatment of the primary tumor, the cumulative mortality rate remains high, reinforcing the fact that this is not just an eye disease, but a life-threatening systemic malignancy.
We have reached the most complex neural tissue in the eye, the retina. We must remember that this is structurally a direct neural extension of the central nervous system, originating embryologically from the diencephalon. It's a dense, bilayered structure essential for perception.
Indeed, it is composed of the neurosensory retina and the underlying retinal pigment epithelium, or RPE. The RPE is critical for maintaining the health and function of the photoreceptors. Anatomically, a crucial detail for pathologists and ophthalmologists is that fluid, exudates, and hemorrhages do not accumulate randomly. They tend to accumulate specifically in the outer plexiform layer.
So when a doctor sees a hemorrhage on a fundus exam, the shape or location tells them precisely which layer of the neural wiring is leaking.
Precisely. For example, a dot hemorrhage is typically located in the outer plexiform layer, while a flame hemorrhage is more superficial in the nerve fiber layer. The layering of the retina means that pathology organizes itself predictably.
When the neurosensory retina separates from the RPE, we have a retinal detachment. This is often an acute, sight-threatening event. What are the two main mechanical types of detachment?
The most common and urgent type is rhegmatogenous retinal detachment. The key element here is the retinal break, a full-thickness tear in the retina. This tear allows the liquefied vitreous humor, the gel that fills the eye, to seep through the tear, accumulate in the space between the neurosensory retina and the RPE, and mechanically pull the retina away.
So it's a tear and traction problem.
Vitreous traction is the primary mechanical driver here, yes.
And the second type, the non-rhegmatogenous detachment.
This separation occurs without a break. Instead, it is caused by something actively pushing the retina away from the RPE, most commonly by fluid exudates leaking from damaged vessels beneath the retina, which is an exudative detachment, or by tumors physically elevating the retina. The diagram showing retinal detachment clearly illustrates this separation, highlighting the importance of the tear location in the rhegmatogenous type.
Because the retina is essentially visible brain tissue, it is extremely sensitive to changes in systemic circulation, making retinal vascular disease a major cause of vision loss. Let's start with hypertensive retinopathy. What visible signs signal chronic, poorly controlled high blood pressure in the eye?
Ophthalmoscopy allows us to see the systemic vascular damage in real time. Chronic high blood pressure causes generalized narrowing of the retinal arterioles. As the vessel walls thicken due to arteriosclerosis, they reflect light differently.
Okay.
Clinicians describe this as copper wiring, where the vessel appears rigid and orange, or if the lumen is almost completely obliterated, silver wiring. These are direct visible signs of system-wide vascular damage.
If we look at the pathology of hypertensive retinopathy microscopically, what confirms this damage?
The H&E analysis is definitive. We see signs of endothelial damage and leakage. One key finding is an exudate that has accumulated in the outer plexiform layer. This exudate, composed of leaked protein, fat, and fluid, signifies vascular damage and leakage into the retinal tissue. We also see microinfarcts, known as cotton wool spots, which represent areas where the nerve fibers have died due to sudden ischemia.
The other titan of vascular damage is diabetic retinopathy, the leading cause of new vision loss in working-age adults. This condition is categorized into non-proliferative and proliferative stages, driven by long-term hyperglycemia. We're essentially watching the body-wide microangiopathy play out in the eye.
That is precisely the insight. The initial damage stems from hyperglycemia damaging the basement membranes of the retinal vessels. The pathology shows a remarkable parallel to kidney damage. The thickening of the ciliary body basement membrane and the accumulation of mesangium-like material, mirroring the damage seen in diabetic nephropathy.
What defines the non-proliferative stage?
This stage is confined to structural problems within the retina itself, often called background retinopathy. The hallmarks are microaneurysms, which are tiny ballooning outpouchings of the capillaries, various types of hemorrhage, heart exudates, and intraretinal microvascular anomalies, or IRMA, which are aberrant vessels trying to shunt blood past damaged areas.
But it's all contained within the retina.
All of these changes are confined inside the retina's surface layers, yeah.
The most dangerous stage is the proliferative stage. What is the defining characteristic that turns background damage into an active threat?
Neovascularization, the explosive growth of fragile, abnormal new vessels driven intensely by VEGF due to chronic oxygen starvation. These vessels grow on the optic nerve, called NVD, or the retinal surface, NVE.
And these new vessels are a disaster.
They're catastrophic because they are weak, leading to massive, sudden vitreous hemorrhages that cloud vision. Even worse, they're accompanied by fibrous tissue, which contracts, causing traction retinal detachment by physically pulling the neurosensory retina off the RPE.
Next, age-related macular degeneration, AMD, the leading cause of irreversible vision loss in older adults, specifically targeting the central vision area, the macula.
AMD comes in two forms. Dry AMD, or atrophic, is the most common form. It is characterized by the slow, progressive loss of the RPE and the crucial, irreversible deposition of drusen. Drusen are extracellular deposits of lipid and protein material that accumulate between the RPE and the Bruch membrane. Their presence signals the chronic failure of the RPE to clear metabolic waste.
And the less common, but faster-acting, more destructive, wet AMD.
Wet AMD, or neovascular, is defined by the ultimate structural failure, choroidal neovascularization, or CNV. New abnormal blood vessels, again often VEGF-driven, grow from the choroid and penetrate through the compromised Bruch membrane into the subretinal space. This causes leakage, hemorrhage, and rapid destruction of the central photoreceptors.
The H&E slides of wet AMD provide the smoking gun. What are we seeing microscopically that confirms this diagnosis?
The microscopic section shows the active pathology clearly. A dense neovascular membrane composed of those new fragile vessels growing immediately adjacent to and often intertwined with the retinal pigment epithelium, the RPE. The vessels have forced their way past the Bruch membrane, forming a destructive complex that leads to scarring and the permanent loss of central vision, the ultimate failure of the RPE-Bruch membrane barrier system.
We must end this section by discussing the most common primary intraocular malignancy of childhood, retinoblastoma. This is a genetically driven, potentially lethal tumor.
It is caused by mutations in the RB gene, a classic tumor suppressor. If the mutation is inherited, meaning it's germline, the tumor is often bilateral, affecting both eyes. This is a very aggressive, small, round cell tumor derived from retinal progenitor cells.
And it often presents with that white people reflex.
Exactly, leukocoria. Early diagnosis is life-saving.
The histopathology of this tumor is highly specific, often sealing the diagnosis. What are the key microscopic features?
The H&E analysis illustrates the characteristic features. While the tumors are generally sheets of undifferentiated small round cells, when they achieve any degree of differentiation, they form rosette-like structures called Flexner-Wintersteiner rosettes. These rosettes are essential for pathological diagnosis. Even more characteristic and readily visible in imaging is the presence of extensive dystrophic calcification, large deposits of calcium within the tumor matrix. This dense calcification is one of the most reliable features of retinoblastoma.
Our final section focuses on the output cable of the eye, the optic nerve. It is crucial to remember this nerve is unique because it is technically a tract of the central nervous system surrounded by meninges and cerebrospinal fluid, making it a direct pipeline to the brain.
This direct connection to the CNS means that diseases affecting the brain can manifest here, making the optic nerve a critical diagnostic window. We start with anterior ischemic optic neuropathy, or AION, which is the ocular equivalent of a mini-stroke.
AION is an infarction of the optic nerve head due to a lack of blood flow ischemia from transient flow interruption or emboli. Why is the resulting visual damage often permanent?
Because the optic nerve is CNS tissue, it fundamentally does not regenerate. Damage is permanent and often segmental, meaning only a specific portion of the nerve is affected, leading to permanent, often wedge-shaped or sectorial visual field loss.
The clinical photograph of AION shows a pale and swollen optic nerve head in the acute phase. How is this distinct from the next condition, papilledema, which is also optic nerve swelling?
They have completely different causes and presentations. AION is a primary vascular event leading to infarction. It is typically unilateral and often associated with pain due to the acute swelling in the tight space of the nerve head.
Whereas papilledema is a secondary pressure effect.
Correct. Papilledema is swelling of the optic nerve head caused by chronically elevated cerebrospinal fluid pressure, or CSF pressure. Because the nerve sheath is continuous with the dura of the brain, high CSF pressure is transmitted down the nerve, leading to compression and edema.
And it's usually painless in both eyes.
Clinically, papilledema is typically painless and usually bilateral. This is a critical distinction because papilledema forces the clinician to immediately look for a mass, hemorrhage, or hydrocephalus in the brain.
Another key condition that attacks the optic nerve is optic neuritis. What is the most famous systemic association here?
Optic neuritis is inflammation of the optic nerve, often linked to demyelinating diseases. It is frequently the first clinical manifestation of multiple sclerosis, or MSK. An acute attack causes rapid vision loss, which, fortunately, often shows recovery. However, a single episode of optic neuritis significantly increases the long-term risk of developing MS.
The most common chronic condition affecting the optic nerve is the insidious progression of glaucoma. How does sustained high intraocular pressure physically translate into damage to the nerve head?
Elevated IOP exerts mechanical pressure on the delicate nerve fibers where they exit the globe at the lamina cribrosa. Over decades, this pressure causes the atrophy and death of the retinal nerve fiber layer, leading to the gradual loss of the axons that form the optic nerve.
And this leads to the classic pathological and clinical feature known as cupping.
The clinical image comparison provided is stark. In the glaucomatous eye, the central cup of the optic nerve, where the blood vessels enter, shows dramatic enlargement and deepening. This is the cupping we talk about.
And under the microscope.
Microscopically, this corresponds to the severe thinning of the retinal nerve fiber layer and the progressive, irreversible atrophy of the ganglion cells. Severe cupping is the physical, permanent representation of chronic high pressure leading to neural tissue death.
Finally, we arrive at the absolute worst-case scenario, the end-stage eye, called physis bulbi. What is the definition of this condition and what catastrophic events lead to it?
Physis bulbi is the anatomical end stage resulting from devastating trauma, severe chronic inflammation, or long-standing unresolved retinal detachment. The eye becomes small or atrophic, soft or hypotonic, and internally disorganized.
What are the pathological hallmarks found in an eye with physis bulbi visible microscopically?
Several distinct changes define this irreversible state. Chronic retinal detachment and disorganization, the presence of old blood or exudate between the ciliary body, choroid, and sclera, and crucially, the presence of intraocular bone.
Bone.
Yes. This bone forms due to osseous metaplegia of the retinal pigment epithelium. The RPE transforms into bone-forming tissue. This bone formation is the definitive microscopic sign of the eye reaching this end-stage terminal state.
And clinically, the low intraocular pressure hypotony in these eyes even affects the external appearance.
Yes. Due to the chronic lack of pressure, the normal tension exerted by the extraocular muscles causes the globe to lose its perfect spherical shape. Clinically, the eye may appear square rather than round. It is a sad physical manifestation of total structural and functional failure.
If we connect all this to the bigger picture, our detailed journey from the orbis confinement to the optic nerve's final atrophy reveals a fundamental truth about ocular pathology, doesn't it?
It does. Localized pathology in the eye is rarely isolated. It often reflects severe systemic conditions. We saw direct, profound links between the eye and Graves' disease, diabetes, rheumatoid arthritis, sarcoidosis, and multiple sclerosis. The eye is our most accessible window into the body's vascular and nervous systems.
And the microscopic pathology, the cellular evidence we spent so much time on, is the ultimate source of truth. We established that diagnosis rests on H&E slides showing dystrophic calcification in retinoblastoma, the lethal distinction between spindle and epithelioid cells in uveal melanoma.
The continuous destructive fibroblast cycles in herpes keratitis, and the definitive difference between simple retinal exudates and the formation of intraocular bone in the physis bulbi. The structure of the eye is the map, but the microscopic detail is the compass for diagnosis and prognosis.
We've seen that the delicate balance required for vision-perfect transparency, precise fluid pressure, and neural integrity is just so easily disrupted.
It is, and the key insight is that even common benign-appearing symptoms like chronic inflammation can hide rare, life-threatening malignancies like sebaceous carcinoma or signal the aggressive metastatic potential of uveal melanoma, often hiding silently in the choroid.
So here's where it gets really interesting. We've covered a remarkable amount of complex, integrated pathology today, focusing heavily on how vascular and neural tissue interrelates. We've seen that the eye is a highly susceptible site for metastatic disease, especially the uvea, and its direct connection to the central nervous system via the optic nerve makes it unique among organs.
This raises an important question for you, the listener, to mull over. Given the eye's extreme sensitivity to both vascular leakage, like in diabetes and AMD, and tumor spread, like in melanoma, how might future molecular therapies specifically target the growth factors, like VEGF, and the vascular structures of the retina and choroid to prevent both neovascularization and tumor growth, without harming the highly sensitive, non-regenerating neural tissue that lies immediately adjacent to the vessels? Think about the unique challenge of designing precision medicine for a neurovascular organ where millimeters mean sight or blindness.